Good morning, everyone. I am presenting on behalf of Medicine 5. My topic is Absquare. A 52-year-old gentleman, Mr. X, a teacher from Bihar, has come with a complaint of fever for 6 months, loss of weight, loss of appetite for 6 months, skin rash for 6 months, and melena for 15 days. And history of presenting illness, he was apparently well 6 months back, and when he started having fever, which was low grade, intermittent, relieved with paracetamol. The frequency of fever was he was getting fever weekly 5 days and afebrile for 2 days, and he was also had skin rashes for the past 6 months, which was in the upper back, abdomen, and the upper thigh and upper arm. He also had loss of weight and loss of appetite unquantified for the past 6 months, and he recently had melena for the past 15 days, which was not associated with abdominal pain or hematemesis. And he did not have headache, eye pain, cough, breathlessness, abdominal pain, vomiting, loose stools, dysuria, or joint pain. Treatment history wise, he started having all the symptoms from September 2024, but he started evaluating from October 2024. So he went to multiple hospitals and he was giving symptomatic treatment only. All this time he had pancytopenia in October, November, and October we went to one hospital, and November he went to one hospital. He had pancytopenia. Hemoglobin was low, and total counts were low, and platelets was low. He had pancytopenia, but he did not evaluate for the etiology for the pancytopenia. And he went to November Ames Patna, where he was advised bone marrow for the pancytopenia, but he didn't do. He just received one transfusion for the low hemoglobin and lost follow-up after that. Past history wise, he is a known case of rheumatoid arthritis for the past 20 years. He has been on methotrexate, leflunomide, and hydroxychloroquine. He has been taking prednisolone for the past 20 years. He has been discontinued the prednisolone after he developed all the symptoms for the past 6 months. And then no other, and he has a history of TB involving the bone, but we didn't have any reports which bone which was involved. But he has received 18 months of ATT history obtained from the son, and he had left leg ulcer debridement done in 2023. And vitals on arrival in the ED was BP 80-60. The peripheries were warm and non-fluid responsive. So we started him on noradrenaline, 5 mg of noradrenaline initially. And then pulse rate was 124 regular, and temperature afebrile. Respiratory was 22, and saturation was 96. On arrival to ward, he has become more tachypneic and connected to BiPAP. And cutaneous examination showed papules and plaques on the upper back and abdomen and upper thigh and upper arm, and scaly ill-defined papule involving the groin and upper abdomen. And examination wise, there was positive findings for pallor present, and respiratory wise, there was a bilateral interscapular and infrascapular crepitations present, and there was abdomen, there is a hepatomegaly of 10 centimeter below the subcostal margin, and splenomegaly of 8 centimeter below the subcostal margin, and no shifting dullness. These are the positive examination findings. So, clinical syndrome of classical pyrexia of unknown origin with a skin rash with a hepatosplenomegaly. These are the differentials considered. So considering the classical pyrexia of unknown origin with a hepatosplenomegaly skin rash, the first differential we considered was extrapulmonary tuberculosis, and is a old age. Next, leukemia, lymphoma we considered, and sarcoidosis we considered, and he is a known case of rheumatoid arthritis receiving steroids for the past 10 years and underlying immunocompromised state. Known case of rheumatoid arthritis also, so vasculitis also we have considered, and HIV with opportunistic infection and disseminated histoplasmosis, and then infective endocarditis, malaria, brucellosis in the descending order. And then we have proceeded with the investigations based on the differentials considered. Initial investigation showed peripheral CBC showed pancytopenia, total count of 2,200, and hemoglobin of 7.79 and platelet of 29,000. And he also had AKA creatinine of 1.86, but we don't have the baseline creatinine. And and electrolytes were normal. Electrolytes of no dyselectrolemia. LFT also showed a direct hyperbilirubinemia of total bilirubin of 2.14 and TB of 1.81. And his ALT, AST also elevated with 8550, and alphas also elevated with 683. And his calcium is also 9.77. Corrected calcium was 11.3. Hypercalcemia. He had hypercalcemia. And INR also prolonged. He had coagulopathy 1.69. Peripheral smear showed hypersegmented neutrophils with mild toxic changes, and chest X-ray did not show any patches or reticulonodular opacities. And his BBVS was negative. And then infective workup has been done based on the differential considered. 3 blood cultures has been sent, which was negative. And He is from West Bengal. He had skin lesions. We have to consider leishmania also as a differential diagnosis, but the anti-RK39 antibody was negative. And echoes done to rule out the infective endocarditis. There was no vegetations. And VB was negative. Ultrasound abdomen confirmed the hepatosplenomegaly. There was no intra-abdominal collection also. And autoimmune and inflammatory workup done. He is a known case of rheumatoid arthritis. For the flare, we have checked rheumatoid RA factor was negative. AC level was elevated 193. ANA negative. CRP was 127. For the vasculitis workup, ANCAs were negative. And myeloma workup also has been done, which was negative. Serum electrophoresis, no gamma band, and there is immunofixation electrophoresis also negative. And we have done the biopsy, bone marrow biopsy and skin biopsy from the skin lesions, which was awaited. In this course, he was admitted on 3rd, and after 4 days, he has become this hypotension has become worse. He was receiving dual inotropics, and his tachypnea was worse. This was not settled with an NIV, so he was shifted to ICU and intubated in view of respiratory failure, severe metabolic acidosis and respiratory failure. And his acidosis has become worse. And so what do you think will be the and on 8/3 at 9:50 a.m. he has arrested because of severe metabolic acidosis and hyperkalemia. So the biopsy report has come after this death only. So what do you think will be the biopsy report?
What are the systems involved? Summarize what he had.
He had systems wise, he had a skin involvement and abdomen hepatosplenomegaly he had, and hematological involvement pancytopenia. So classical PUO with the pancytopenia with the skin hematological involvement with the pancytopenia with the skin involvement and
kidney injury,
acute kidney injury,
liver involvement,
and hypercalcemia.
Okay.
With the elevated ACE levels.
Okay. Anybody wants to guess?
Sarcoidosis.
Sarcoidosis. Anybody else? Amit also sarcoidosis. Okay. Anybody else? Group sitting there. Somebody from there. Ashwin. Kezia. Okay. Did the patient receive steroids?
No, outside he had received steroids in the November, sir. Yeah, he has that pancytopenia has improved after he received steroids.
Okay, you can go ahead.
So the biopsy showed histoplasmosis. Both the skin biopsy and bone marrow aspirate trypsin had showed histoplasmosis. So the diagnosis was progressive disseminated histoplasmosis with the skin and bone marrow and multi-organ involvement. He is known. So any patient presented with a classical PUO with raised ICE and hypercalcemia, we all think of sarcoidosis as a differential diagnosis. So we should also think histoplasmosis is also one of the differential, because in histoplasmosis also can be presented with the hypercalcemia and raised ICE levels. This is the article New England Journal of Medicine 2000. This is a case reports of 7 case reports of histoplasmosis presented with the hypercalcemia. So my learning point is when patient present with the classical PUO with the hypercalcemia and raised AC level, apart from sarcoidosis, we should also think histoplasmosis is also one of the differential diagnosis. So from the what could have been done for this patient, from the patient aspect of point, when the AIMS partner said November 2024, and that time he was stable, not in the septic shock, he would have done the bone marrow, and that time histoplasmosis was detected, he would have been alive. And from the history, from our point of like we have evaluated correctly only, but he had a septic shock and also before the diagnosis itself he died.
Okay.
Thank you.
It would be good if you had put up a picture of his skin lesions.
Yes.
Maybe that would have also helped us. Okay. Thank you. Anybody, please give her a hand. Anybody wants to ask any question or add anything? Okay. So I think we have one last presentation from Chittur. Shaktivel is presenting resistance in the air. Is he connecting from Chittur?